Thank you, Dr. Khanna. Yeah, is my slide visible?
Yeah, it's visible.
Yeah. So I have kept it kind of more practical talk. Dr. Satvik has given a very nice, detailed, practical as well as the physiology and the physics of the Doppler, and even he has revised lot of stuff for me. Very great talk. So that made my things more simpler. So I'll be talking about duplex scan for basically the venous side. So the principle doesn't change, the machine doesn't change. All you have to know is about the anatomy and the difference between the arterial and the venous system, their characteristics. So we all know that we all work on a duplex scan. So we should know our machine. There are n number machines available. The basics are same, but the buttons and a little differences are definitely there. So you should know your machine before you go for the scan. So there are a lot of functions like preset, probe selection. Dr. Satvik has already told about the hockey stick, the linear, the curvilinear probe. So usually a duplex scan is done with curvilinear probe unless you're doing for an abdomen, which he has nicely explained. So we should be aware of the V mode, the color mode, the other power Doppler and other stuffs. So PRF is like pulse repetition frequency, which he has already explained. Gain, depth button, the scan area, the velocities, the baseline on which you will be calculating, and the frequency. So you should know your machine before you begin. That's the basic what I wanted to highlight. So when we are doing for the venous system, what is in our mind is the patient will come either with visible veins on his leg or her leg. There will be a swelling in the leg. The patient may have some pain, hardness in the calf region. So these are like typically indications where we will be doing a duplex scan. The suspicion for DVT, post-thrombotic syndrome, or it's called as chronic venous insufficiency leading to that. And then there is a huge field for dialysis access in which you'll be doing a vein mapping pre-procedure and a surveillance and maybe a post-procedure. So these are typical indications. So the most commonest, especially in our country or maybe worldwide, for which we will be doing venous Doppler is the varicose veins. So we should be aware of the anatomy and the pathophysiology and the pathological changes, because so varicose veins are those which are long, dilated, tortuous veins, and there are many reasons for that. Primary varicose veins, and then there are secondary varicose veins. So coming to this, as I told at the beginning of my talk, unless and until you know the anatomy, you know the pathological changes which happen in the varicose vein, it won't be that easy to interpret on your duplex scan. So you should know the great saphenous or the long saphenous vein, the deep venous system, the junctions or the SFG or SPJ, what we call, and then you should be aware of the perforator anatomy. So let's go ahead. Here you can, so the information desired by yourself, if you are a treating interventionist or somebody is relying on you, you should give detailed about the deep venous system, the superficial system, the junctional competence, incompetence, where the valves are located, the calf veins, the perforators, whether they are flowing one way or two way, or they are dilated, where there is a thrombus around, and the compressibility. So these are few things, and especially you should, while doing this, you can evaluate the arterial system simultaneously. You can look for the basically remember the nerves when you are an operating interventionist doing a varicose vein procedure basically. So SFJ is like and communicates with the common femoral tributaries around. So you should be aware of this. There can be dilated, could be the culprit all group, and never miss the deep venous system. Even before starting for a scan on your superficial system or a perforator, go for a view from the abdomen, see the patient clinically, even if you are not a treating interventionist, you're just doing your basically your diagnostic stuff, always lighten your room, have a look on the belly, the groin, whether there is no varicosities, no secondary varicosities on the belly, and then you get a fair idea. You can talk to the patient whether he had a bad swelling in the leg or in her leg, which was for maybe days or weeks. So you get uh, usually dilated, flowing, traveling around it. So this was basically a vein of Kaikomini, and then the deep venous system. The flows, whether there's an obstruction or not, external compression or not, the reflux, deep vein reflux is something which has to be looked for apart from the junctional reflux. And then you look for your perforators and ask the patient to stand, lying position. So I'm talking really practically what are the steps you have to do during the examination. Then presence of DVT and superficial thrombophlebitis. Always try to assess the arterial system. Sometimes if the patient is like old age, 70 plus, 80 plus, and we are looking for varicosities, but they if they are diabetic, they can have a claudication pain. You can talk to them, look for the arterial system simultaneously. That would be an additional information we can save his leg. So characteristics, coming to the characteristics of the vein, usually, yeah, we know that they are thin walls compared to the arterial system, and they are kept open by the transmural pressure. They are compressible. So here you can see they are easily compressible with light pressure on your probe. So while doing the examination, you have to hold your probe like a pen and don't compress it a lot. Otherwise, you won't see your vein in the groin, and if the patient is thin. So you have to hold it really gently. So they are nicely compressible. You can oppose the walls. And then you look for the venous Doppler patterns. There's spontaneous, the physicity, it augments with the distal compression. If the pipeline is open, there is no external compression, there is no internal obstruction or a thrombus, no significant reflux with proximal compression, and they are non-pulsatile. They are not an arterial flow. So if it becomes a pulsatile, then you will think about the valvular problem in the heart, or there could be an AV fistula or a AVM. So usually they are non-pulsatile. So here again on this clip, you can see how easily they are compressible. Here on the color mode, and there it's a B mode, basically a 2D. So coming to the compression USG, complete coaptation of the vessel wall, that is normal. Whenever there is an abnormality, you may have some partial compression, or it will be completely non-compressible. But few points to be kept in mind are, some veins are normally difficult to compress, especially the distal femoral popliteal region, because they are deep, there is muscle. Sometimes you may feel if the patient is really bulky, the thigh is hefty, then you may not be able to basically compress it. So this is like an anatomical difficulty. Then you'll have to see the popliteal region proximal to this. You have to use the knowledge of your physicity, the augmentation and all that, to rule out there is no clot or thrombus. So that should be kept in mind. So if vein is non-compressible but no thrombus is visualized, consider obstruction. That means there may be the other causes apart from something intraluminal. That is what I mean. So factors that affect vein diameter, definitely patient position. If he's standing, his physiology, if he came after running stairs and all that. So things change with the patient's position, the status, whether he's resting or not, whether you are compressing proximally or not, and with the Valsalva maneuver. So you have to keep that in mind. So it's a little different from the arterial system. So looking at this clip, you can see there is no flow, the vein is distended, and the central lumen is showing some echogenic, hyperechoic structure. Talk to the patient, examine him clinically. So this is most likely a DVT. So whenever a DVT is diagnosed, our job doesn't end there. You have to look for the extent, start tracing it till the belly, because the treatment changes with that, whether the patient needs simple anticoagulation or he needs some intervention. So degree of attachment, echogenicity, the texture, that helps us to correlate with the patient's history, whether it is acute, subacute, chronic, and that additional information is very important to plan the treatment. So here you can see there are some differences where you can, apart from the patient's history, sometimes patient will not realize when he developed. So if it's acute thrombus, there are a few characteristics, although they are not 100% diagnostic, but it's very helpful. Acute thrombus is lightly echogenic, poorly attached to the venous wall. It has a spongy texture. You can be, if it's very, very acute, hyperacute, you can easily compress it and oppose the wall. Smooth borders, the veins are dilated. So acute thrombus will be hyperechoic and difficult to see on B mode without increasing your gain. So try to remember that it will be very, very jet blacky if it comes very. And if there is a chronic thrombus, there are a few characteristics like it becomes echogenic. There may be some calcifications, very, very old. It's well attached to the wall, rigid in texture. You may not be able to compress the vein. And with over time, the vein gets contracted, fibrosed. There may be irregular borders, and you may see some collaterals flow opening up. So this is the longitudinal view of chronic DVT scan. And then there may be a recanalized flow pattern. Here you can see that the recanalization starts with the anticoagulation, which is given with the patient's fibrinolytic system. So here you can see an easily diagnosed chronic DVT. So you should remember acute DVT, chronic DVT changes, and always talk to your patient. This is new vascularization of the thrombus, which can happen in the region of the wall. So regarding the technique, especially for the lower limb, I'll be talking. So ask your patient to relax, lie down. The jelly should be a little warm. Make the patient comfortable. And then with a little frog leg position, you can scan the entire lower limb starting from basically common femoral. But as I told you, I personally prefer looking from the iliocaval confluence and coming downwards so that I don't miss the iliac or the IVC lesion as well, even if the patient is referred for lower limb pathology. So this is the ideal typical position for the lower limb. So you see, start from the groin region in transverse longitudinal section, look for the deep venous system, and then start scanning your superficial system. As you come down, this is the region where you can look for distal femoral vein, which is called as superficial femoral vein as well. And you can easily look into the popliteal fossa in the longitudinal and as well as the transverse scan for the popliteal venous system. And as there are few important points, but be cautious not to mistaken the often prominent muscular. So in some of the patients, the gastrocnemius muscles are so prominent that we can mistaken it with the basically the popliteal vein. So it's just a piece of information. So as you go down, things become difficult, and your expertise increases with the number of scan you have done. The veins are tiny. If the patient is really hairy, patient is basically heavy built, it becomes difficult. So so try to keep your probe as it is shown on this schematic diagram, and try to look for basically the posterior tibial and the peroneal veins. These are paired veins. Look for them on the cross section as well as the longitudinal views, and they are always paired, run along with the arteries, and try to look for any thrombus or any other lesion. Sometimes you may encounter with an AV fistula post gunshot. So these are the region which has to be looked for. So we usually go for anterior tibial, posterior tibial, and peroneal veins, but it takes some patience and can be easily done. So once this deep venous system is done, the superficial system is done, you look for the perforators. So I always try to make the patient stand, follow your deep venous and the superficial system, go along with that with the probe, and then we know that there are certain perforators which are to be looked for, and we should go for that. So coming to the perforator, what we look for is the diameter, the flow pattern, whether it is from superficial to the deep, whenever patient does a Valsalva, whether it goes into it's a bidirectional flow. So that is again important to call it a incompetent perforator. So this is a video clip where we have demonstrated how to look for a SPJ reflux, so SFJ reflux. So it's a saphenofemoral junction reflux. So this is the baseline, and the patient is asked to do a Valsalva. explain him very well what he has to do. Sometimes he may or she may not be doing a proper Valsalva, you may report it to be normal. So usually there is a small jerk, and by criteria it should be more than 0.5 second. So look for a continuous reflux, and before calling it a incompetent valve. Here you can easily see that how it goes above the baseline whenever a patient and the color changes. So that's how we look for a reflux. So again, this is like kind of flow where you can get mistaken. It's basically an arterialized flow, but the patient may have the abnormal structural heart disease, which can be an issue. Sometimes the patient may have an external compression, which can lead to distension of the veins and then secondary reflux. So you have to be aware of that. Again, a lot of patients with post-thrombotic syndrome would be referred to you. This is basically a patient has basically a DVT, took a treatment, is not compliant, not wearing stockings, develops an ulcer, and then he comes to us. So basically, these are post-thrombotic syndromes, and one should look for the entire deep venous system, and look for deep venous reflux, look for collateral flows, look for secondary incompetence of the valves. And this is very, very important, because if somebody operates on them, it becomes a nightmare. Somebody wants to treat the patient for varicose vein, and then he lands up losing the limb. So these are basically secondary varicosities, can be easily recognized by taking history and clinical examination, but Doppler is a fantastic tool, and we can easily make it out. And this is just an angiographic picture or the DSA picture of such patient. So this is just an image which shows deep vein, there's a reflux, and then there is a thrombosis, superficial thrombophlebitis with in a patient with secondary varicosities, and then suddenly they are pro-thrombotic, and then the superficial varicosities also get thrombosed. Another case of recurrent venous ulcer in which the laser was already performed, but there was an incompetent perforator. Here you can see a sclerotherapy was done, and you can see how the basically foam, which is basically a sclerosant and air, is seen. So this is just few clips which will show the perforators. So here you can see it's crossing the fascia, it's dilated, and you can easily see here between the communication between the deep and the superficial venous system. So a perforating vein joins the superficial veins to the deep veins. By definition, a perforating vein must be reaching the fascia between the superficial fat and the muscle. So that's how it's very easy to demonstrate if the patient is standing. And these are like usual ones which we look for: pockets, boils, below the knee, dots, and Hunterian. You should be aware of this. So coming to, yeah, it's just a measurement where you can see how it can be easily seen. It's a dilated one. And these are, believe me, these are real culprits for recurrent venous ulcers even after treating the truncal veins basically. Coming to other spectrum, and go quick. These are like vascular malformation. They could be pure venous, could be mixed, could be high flow AVMs. So Doppler plays its own role here. You can look for few things. Whether there is AVM, then there will be an arterial flow on the venous side. If it is pure venous, you may see that there is very low flow spectrum, especially like a venous one, and there could be lymphovenous. An MR imaging or a CT imaging will aid in that. Do a local examination, look for temperature. Here you can see a nice phlebolith. This was a venous malformation. And then it gives a lot of information, planning, where to access, whether to go for arterial system, whether we should take a venous access or both access, hybrid, whether it needs a debulking. So we can give a lot of information to the treating physician basically. This is like a post-operative scan where you can see coil. And this is just a example of that. So how the arterial flow, and then there was a venous access taken, embolized. Another spectrum where the Doppler we do usually is for the pelvic congestion syndrome, where the females come. Usually TVS is very helpful in this situation, and you can diagnose the pelvic congestion. These are the chronic pelvic pain female patients, and this is very helpful pre-procedure and post-procedure. This is how the imaging looks when we treat it. So you selectively go into the ovarian vein and then embolize. So this is again very important. Few important points, that structures that can be mistaken for veins are sometimes lymph nodes. It does not have a clear-cut difference between the hyla and the periphery. The Baker cyst can be easily made whenever a patient comes with a ruptured Baker cyst. It can be misdiagnosed as a DVT, hematomas, and abscess. But with the experience, I mean, yeah, definitely we can make out. But in the early phase, we can definitely have a problem in the initial stages. So that should be kept in mind. Whenever you give a report, you should give a complete report right from your belly downwards. So talk about the CFV bifurcation, SFV proximal, distal, demonstrating patency. So every vein deep and the superficial system, the perforator should be commented, and any other finding you see in this during the scan should also be mentioned. So venous nuclear scanning is extremely sensitive and cost effective in the hands of experienced operators. For identification of DVT, sensitivity is pretty high if done properly. Used to assess valve function, monitor thrombolytic therapy, long-term follow-up. Thank you.